Hello, I'm Joan. I'm a Canadian family physician who also works as a restorative medical educator, facilitator, and coach. I create spaces that rehumanize the work of healthcare. I'm creating this podcast to remind myself, as well as anyone else working in a helping profession, that when you are working and caring for your human patients, you are the other human in the room. Hello, healthcare humans. Thank you so much for coming back for another episode of The Other Human in the Room. So, today we have another healthcare human conversation. And I think I say each of these is special because they are to me. Anyone who gives an hour of their time to talk to another human in healthcare about how they're making it work, how they're making healthcare feel more human for them. I am just infinitely grateful for their time. And in this case, it's a special connection because, again, it's someone that I've known for a long time. So today I'm speaking with Dr. Naheed Dosani, and he and I go way back. We went to medical school together, and it was clear even then that he had major leadership potential. Like, he was the president of our class, and it was clear he was passionate about leadership and advocacy and changing the healthcare system for the better even back then. But honestly, I would not have predicted how much he's been able to accomplish since we've left medical school. Everything that he has done, I swear I turn on the internet and there he is with like a really powerful tweet or op-ed or article. And he's so passionate about caring for folks who experience homelessness. And I will let you listen to him talk all about his passion. And I'm just so grateful he took the time to talk to me. And so I did want to introduce him formally, just so you know some of the background of who he is in terms of his job titles. So, Dr. Naheed Dosani is a palliative care physician and health justice activist. He is a palliative care physician at St. Michael's Hospital in Toronto. He is the lead physician of the Palliative Education and Care for the Homeless, aka PEACH, Inner City Health Associates. That's the PEACH is a branch underneath of Inner City Health Associates. And he is also an assistant professor at the Department of Family and Community Medicine at University of Toronto. So those are the titles that he holds. But of course, as a human, he embodies so much more than that. I will say, though, that these particular titles and what he has done for the healthcare system, not only just locally in Toronto, but well beyond that in terms of advocating for humane palliative care for those who experience homelessness, is really inspiring. And one thing I will say to each of you listening is, you don't need to now go and like create a whole new initiative in order to make a difference in your corner of the healthcare system. But what I'm hoping that you hear is how Naheed really focused on what mattered most to him. We all come to healthcare, and whether you're a physician or work in healthcare in another aspect, and I think we all have something in our heart that made us come. And then along the way, through training and sort of embedding ourselves in healthcare culture, some of that can get lost. And instead, we are trying to do what we think everyone else wants us to do in a million directions, and then we feel lost. But one thing I really admire that Naheed has done early on and continues to do is really stay focused on why medicine meant something to him and ensure that the work he does is what fires him up and fills him with so much passion and energy that, sure, burnout is always a part of the equation. We have to be careful for that. But he is doing what matters most to him. And that in and of itself is enriching. And that's something I found to be true for me. And unlike Naheed, I didn't know it from the start, but discovering it now through the work I'm doing, say with this podcast, I can tell you how much more energy I have and how much better fuel it is to know what it is about healthcare that actually lights you up. So I hope you can hear that in how he communicates everything he's doing, and ask yourself this question: what is it that lights me up about working in healthcare? And how could I narrow what I do in healthcare to really serve that passion best? Okay, so that's my intro. And I hope you all enjoy this conversation with Naheed. Get started. Okay. Hello, healthcare humans. Thank you for coming back for another episode of The Other Human in the Room. I have a very special guest on the podcast this week. And actually, I wouldn't mind if you introduced yourself, Naheed. How do you like to introduce yourself these days? I'm curious because you have a lot of hats that you wear. So how do you sum it up?
Yeah, so I'm Dr. Naheed Dosani, and I'm a palliative care physician who spends a lot of time providing healthcare for people who experience structural vulnerabilities like poverty and homelessness. My clinical care spans from hospital to community, including like the streets and in shelters, to hospice as well, and everywhere in between. When I'm not doing that, I spend a lot of time trying to advocate around health justice issues, and am really committed to training the next generation and building a brighter future in those ways.
That's amazing. And the ways, just to say how we know each other, like I was saying before we started recording, like I think if you are in healthcare and have the internet, like probably you'll have seen like one of Naheed, your amazing like articles or tweets or like all the work you do online, which is so good. But then you and I go way back. You were the president of our medical school class way back in the day.
You're far too kind, and yes, we do definitely do go way back
Yeah, which
to
is
our
fun.
medical school days. Yeah, it's a total throwback. It's amazing.
So good. I just was like, what? It's just been amazing actually to see you do this work, and it's super inspiring because like, you can get caught up in there's versions of the medical culture where you can really get caught up in the version of medical culture that kind of already exists, which maybe the more whatever traditional where it's like pure patient care, and you have to follow a certain track or something. So I'm always very
Mhm.
curious. Actually, that's how I'd love to start. How did you know that your version of what you wanted to offer to, the world and healthcare was going to be patient care plus other elements? Like, how long have you known that you wanted a combination um,
Yeah.
you know?
Yeah, it's a really good question. And just to put it out there, I was born to two parents who came to Canada as refugees in the 1970s from a country called Uganda. And so my upbringing was very much focused in Scarborough, Ontario, about just really about justice, the immigrant refugee experience, community well-being, and ultimately the social determinants of health. As I went through my schooling, I started to realize there were different avenues to inspire social change in our communities, and I landed on healthcare mostly because the ways that I was seeing that our colleagues who are working internationally for organizations like Oxfam or Medicine Sans Frontières, like what Doctors Without Borders, and things like that, and what they were doing. And then I ended up in my residency program after we finished medical school at McMaster and ended up at the University of Toronto. And it was there that I had this really traumatic event while I was providing primary care at a local shelter, where I met a young man who was in his early 30s who presented with a head and neck cancer. And he was a person who was on the streets. He was experiencing mental illness. He had schizophrenia, and he was a person who used drugs, and he lacked adequate access to cancer care. His tumor grew and he started to experience pain. And he went from healthcare institution to healthcare institution and could not get access to pain medicines to treat his quality of life. So he found himself in our care. And despite my best efforts, he had died by suicide on my watch, essentially,
Hmm.
because he couldn't get adequate access to pain control, despite him promising me that he would work with me to connect with me and get some adequate pain control going. And so this was a really traumatic event for like the entire community that he lived in, but also a very traumatic event for me as a learner. And I would say was probably a turning point in my career, but certainly in my life for sure. In addition,
Yeah. What did that mean to you? Like how do you think that shaped what you've done since then?
I mean, it was at that moment that I realized that I was obviously aware that people who experience homelessness and poverty in a city like Toronto lack adequate access to supports and care. But I was shocked that even like I knew that this happened during life, but
Yeah.
I was shocked that this was happening at the end of life, right? And to me, like from a humanity perspective, if we can't get things right to support our most vulnerable when they're dying, how are we going to do it when they're living, right?
Mm.
And this led me down a road of really becoming quite um, interested, maybe even obsessed with the intersection of homelessness and palliative care. And what I learned was actually this was a global phenomenon, not just something that was happening in Toronto. In many high income countries around the world, there was actually a phenomenon of people experiencing homelessness, dying, and having and suffering, in whatever city you're in. People who experience homelessness live a lifespan that's typically 50% of people who are housed. So homelessness cuts a person's lifespan by half. And so, in and of itself, homelessness is a social terminal diagnosis, you know?
Mm.
And so it just led me down this path to learning more about this huge deficit in our healthcare system. And I realized we had to do better. We had to make a change, you know?
Yeah. Wow. I mean, what you just said, homelessness is a terminal diagnosis. Like it's so like I mean, there's so many examples of how we treat people generally in society shows up at the doorsteps of healthcare. And this would be one of those examples where if healthcare would look different if we lived in a society where it was set up in a way that no one was unhoused, or certainly in the way that they're unhoused in our society. Um, uh, I'm wondering with that, like, you'd said how you had this shock and maybe have gotten a bit obsessed. You said those words and I was like, how do you then take that? Because that was, a minute ago, a few years now, right? Um, how do you turn that into sustainable fuel to do everything you're doing? And I mean, this podcast is primarily about helping to sustain people who want to stay human in how they practice healthcare. And I can just imagine when you're really focusing on the people or a group of people that are experiencing such unnecessary suffering at the hands of others, what does that look like for you to sustain yourself through that?
Yeah, no, for sure. I mean, I think it was such a heartbreaking moment, obviously because of his death. His name was Terry, by the way. So when
Mm.
Terry died, my heart was broken, and I carry a piece of Terry with me everywhere I go. But it was also a turning point to realize that our health system was very much failing people who experience structural vulnerabilities like him. And there were so many people who are falling through the cracks. And so I just couldn't go on with the status quo approach to medical training. And so I pursued further training in palliative medicine. I did a residency at the University of Toronto after my first residency in that. When I was like in that program, I started to realize it wasn't just homelessness.
Yeah.
It was systemic racism. It was stigma around people experiencing mental illness. Like basically people who got access to care, particularly palliative care, tended to be people who are more wealthy, people who had homes. And I realized if I'm going to continue in this profession, I need to do something that is, to your point, sustainable, but something that is like addressing this issue. Otherwise, I'm going to have this big hole in my heart and I'm not going to be
Yeah.
able to like go on. So I did the whole thing that a lot of people do. Like I went through training, I got a hospital job, but at the same time, I pitched a new way of doing things. We called it the PEACH program, Palliative Education and Care for the Homeless.
Mm.
Um, um, and it was a new program, and I pitched it to an organization called Inner City Health Associates in Toronto, and they said, "Let's do this." And we 2014 we launched the world's first mobile palliative care program for people experiencing homelessness. It started as a program that was run out of the back of my Honda Civic one
Mm.
day a week with myself and a nurse colleague. And fast forward to 2023, the program is a 24/7 operation. We care for 110 to 120 clients on caseload at any given time. We have 7 palliative care docs, a nurse, a home care coordinator, social worker, a psychiatrist. and we're embedded in, home and community care. And the program has been replicated in cities across Canada and around the world. So when you ask me about, what I needed to do to make things and keep things sustainable, I needed to plug into an atypical medical model. And I had to create it with colleagues. Like it didn't really exist for me. The mainstream wasn't offering what I needed to do. And so we had to create something different. And that was Peach.
Yeah. I'm like, yeah, I am like a little bit like maybe we just need to create atypical medical models all over this place for all these days. I mean, maybe there's some, I mean, I guess the appendix is where the appendix is, but like there's a lot of ways that you and I and others listening, the way that we were trained, the system in which we were trained, the history of medicine, and
Hmm.
bringing it to this point. Um, I don't know if you found this. I guess because you came to it knowing about social determinants of health, but I've noticed that sometimes um folks go into medicine thinking there's like this answer, and there's almost like a defensiveness to the way medicine is set up now that then can be hard then to really invite necessary change,
Hmm.
especially if not everyone's ready to really think about how the roots of how, like, say our healthcare system or how we're trained in medical school, like it has roots like in white supremacy and colonialism. I mean, like
For
it's
sure.
got not great roots, Naheed. So
Yeah.
um anyway, now I'm just like, I just think that's so incredible, and it may just be a solution more often than we think to create an atypical model, you know?
Yeah, yeah, for sure. I mean, I think there's a couple big points you're making there. The healthcare system that has, been designed has not been designed for everybody. And in
Yeah.
fact, I'm very aware, as I'm sure you are, that this healthcare system was designed not with unhoused people in mind, or, racialized people, or, people who use
Hmm.
drugs. Like this health system was never designed for them. And that's why we see the outcomes we see, right?
Hmm.
The other thing I think is that, it was not easy to create the Peach program. I mean, I tell it in one fell swoop in a story, but there was a lot of failure, a lot of rejections, a lot of people turning us away when we pitched this idea. And it get, I feel very grateful to have had the opportunity to move this forward with my colleagues and be able to create this new frontier of what health equity can look like through palliative care. But I wonder, because of the fact that we don't incubate and support the incubation of atypical or innovative ideas in healthcare that well, how many great ideas have died on the front lines and
Yeah.
never made it? How many times are learners told when they come on a rotation, "Thanks for joining our discipline, our rotation. This is how we've done things. This is how you'll do things, and this is how we'll forever do things." And that's just how it is. Do you remember that feeling when you were told this is just
Yes.
how it is? And I think
Uh,
that moment is where a lot of great ideas die,
hmm.
or the moments after that. And unfortunately, we don't cultivate fertile soil for innovative ideas to cultivate. I speak about the younger generation, but like, to be honest, any generation in medicine and healthcare. And so, yeah, I often think about that too.
Yeah. I was curious actually, do some, you said training the next generation. Is that also a piece of the work you're doing now?
Yeah, I think that has to be a part of it. We know, depending on what discipline and what you're talking about, that role modeling is essentially the biggest piece when it comes to showcasing what health equity or health justice can look like for, health trainees, whether it's medicine or nursing or any other profession. And so, we've taken, at the Peach program, we were really committed to that, and our team was able to create a medical education rotation called palliative care in the inner city and experience and social accountability, with the Peach program. And basically, what we do is we take learners, they join us, they do the visits, but they also work through a social accountability workbook, and then where they reflect on their past, their own privilege, their values. They practice some advocacy. It gets them thinking through the whole process of what it means to be an advocate and be socially accountable. And this, rotation has become very popular and actually has become a core rotation for palliative medicine residents who are graduating from the University of Toronto. And like that's really cool that the university chose peach to be a core rotation, right?
It's
um,
incredible.
yeah, like and it's very, very exciting, and I think that will probably grow. But and I'm very grateful for what we do. It's just like one example of an experience, and there's not too many experiences out there that exist for people to see health equity in action from a role modeling perspective. And so we need more of those kind of frontline experiences for medical students, residents, and other healthcare trainees as well.
Yeah. I love to know, like, how do you role model, like when say it's your turn to have learners, or even just with colleagues or whatever, especially like the staying accountable piece. Um, I'm imagining it looks very different than, say, the traditional way, like a preceptor would have come to one of us and I don't even like to
Mhm.
PIMP. Remember how we all used to just like that's how we were quizzed, you know?
Mm,
So I'm imagining you have a different approach to how you speak with
yeah,
good learners.
yeah.
And like, how does that really look in real life? Because like you're still a human, and we're all still humans. We're all still on a learning journey. We can never say the right things because they don't exist, right? Like, how do you do that in your day to day work, both modeling for learners, but you just even like in your life? How do you stay accountable?
Yeah, for sure. I mean, I think the first thing is we really focus on learning.
Yeah.
So we spend a lot of time telling learners like we appreciate everything you've learned, but you're going to spend a lot of time unlearning a lot of that when it comes to caring for structurally vulnerable people.
Mhm.
And so, t throw those assumptions, throw your recipe book style approach
Mhm.
to intakes and consults out the window, right? Like this is going to be different. I think the second is that, we really try to frame social accountability to be about the work and the care is about more than just the medicine. And I think in a lot of frameworks, I think we send the message that it's just about the medicine, and in the realm of providing palliative care in the community for people who are vulnerably housed or underhoused, like it's not about the medicine. It's about much more, right? You can go in and prescribe all the right medicine. You're not going to make a lick of a difference in a person's life, right? You got to
Yeah.
think about their housing status, their food insecurity, filling out the right forms to get their income assistance going. Think about their, trauma and their social isolation, and think about getting colleagues involved to get that, addressed and going, right? So there's
Hmm.
lots of things that really need to come together. So I'd say that that's, the second kind of piece. And then the third piece is just recognizing for many health workers, this is really hard work and really building forms of resilience so that people can maintain that resilience as they do this really, really hard work. I'd say those are three huge elements of how we approach medical education in this kind of area.
Yeah. And I think I mean, all the learning in particular, and just knowing that it's a constant unlearning, remembering, unfolding, right? Like we're just collectively trying to like wake up to what we have been taught that wasn't true, to put it
Right,
succinctly.
right.
And that third piece, the resilience. Well, one thing when I think of resilience, maybe it's an overused term these days, but I still really like it, is boundaries.
Hmm.
Because like this isn't gonna get solved tomorrow. Could it if certain dollars changed hands? Probably. But like, in
Hmm.
terms of when you see what you see, and how do you and how have you seen modeled setting up something where the lines beyond medicine are really blurred? How do you then know what's yours and not yours to sort of own about the care you offer your patients? And
Yeah,
how do you set boundaries so that you're not personally working 24/7, right?
yeah. I mean, when you're dealing with health and social, what complex health and social problems like palliative care and homelessness, you literally could work 24/7 for the people you care for
Yeah.
to improve their care and their well-being. And you probably would only be a fraction of the way there to actually achieving that goal, which is wild when you think about it. That's how big the gaps are that people are falling through. So the question is very real, right? You have to be able to set some sort of safe area where you're able to like be productive and put forth your best work, but also be able to go home and be able to move on with the rest of your life, right? And so I think some key parts of that include working in teams that are emotionally not just supportive of the work, but emotionally supportive of each other. And our Peach team is very collaborative in that way. And I think we spend a lot of time supporting each other. I think also recognizing that if we just hit the road hard and doing clinical visits all day long, we probably will experience more moral injury and compassion fatigue. So many of us, if not all of us on the team, do some form of education, research, or advocacy. Some of us are, on the front lawn of Queen's Park protesting,
Yeah.
some of us are writing op-eds, some of us are conducting research, some of us are really into educating the next generation. But I think we all use those avenues as productive means to build resilience and refuel, so to speak. Um, I think we also we mentor a lot. I think that comes in different forms, just internally on the team. Of course, we mentor and support each other. If we have someone new on the team, we support them. But I think what we do also is we mentor other clinicians who are trying to become more equitable in their approach across the city. I'm thinking, you could take this in many ways, but palliative care clinicians, for example, working in different hospitals who are, who call me and want to learn more about how Peach does it, or what would you do in a scenario like this? And sometimes that can be seen as like an extra, call or an extra piece of work, but it's actually really, really fulfilling, I think. And then the final one is that we grieve together, and I think that's one that really needs to get talked about more. We hold grief circles when a client dies. We just stand on a site, or we do it virtually, and we have everyone who's in that care circle, whether social or healthcare worker, join that circle. We hold a minute of silence. We light a candle, and then we cry together, and we laugh together, and we remember what it was like to care for the person. We reflect on what it was like to care for that person, and then we think about ways to renew and reinvest in each other. And then we hold another minute of silence, and then we put that candle out, and then we know we'll probably be back in a grief circle sometime soon, but at least we had those moments together. And so grief circles have been happening on our team since 2015, and we've really, that's been really helpful for me personally, to be able to be part of those circles, to be able to deal with the homelessness crisis, the opioid overdose death crisis, the COVID pandemic. Like there's so much
Yeah.
suffering happening, and so that's been really helpful. So I sorry to go on and on, but those are some of the things that we're doing, I think, to deal with that.
Yeah. I mean, well, it's those are such rich areas, and really like practical examples of how to build resilience. Because I think sometimes it gets put in the box of like do some meditation or something, but it's like you're like
Yeah,
it's structurally set up so that you may cultivate and maintain your resilience, like relying on others. And I am now
for sure.
obsessed with this grief circles. I need to hear how did that come about? Like who, not like who, you don't have to name the person, but like how did it become clear that you needed those? Because why don't we all have those? Like
Yeah,
that's
that's a question.
oh
Yeah,
my
that's the
gosh.
question we ask ourselves quite frequently. I think, it was really after our first year of operating Peach where we realized like we had a prototype here of something that was really important, but we noticed that anytime there was like a death or loss at a site, typically a respite shelter or drop-in, we found that there was significant like a ripple effect of trauma, loss, and burnout that was happening. We
Yeah.
saw many of the workers, often social service providers working in the homelessness sector, having to take leave, for example. Like there was just not really a space or a place for appropriate coping strategies. Like, as if anything is really appropriate when someone dies. It's tragic, right? But
Yeah.
there's just no space for it, right? And
Yeah.
so we ventured to kind of like create something that was, had been previously described in literature, and just bring it to life, using the 4 R's, remember, reflect, renew, reinvest. And, it took off. And then during COVID, we actually got tapped on the shoulder by the city of Toronto to become the official grief response in the COVID hotel program for unhoused people. And so we were running lots of grief circles every week, virtually, for people who are working in the front lines. And yeah, I mean, it's caught the interest of a few people for sure. I mean, like Dr. Brian Goldman, sat in and actually recorded for CBC White Coat Black Art a whole episode on our grief circles.
Hmm.
Um, and yeah, I think that's a good point. Why is this not more common? Like, since we've gone public with this and spoken more about it, we've learned that some pediatric teams do this,
Mm.
some ER trauma teams do this, some ICU teams take 30 seconds after a death. Like, I think that it won't always look the same as the way we do it, but I think people recognize this is important. I hope we start to see more of this these kind of rituals, so to speak, in our work and practice.
Yeah, like I think of like there's ones that aren't this. So say I don't know, like M&M rounds, or I don't know. There's times where things get debriefed in a way that ends up causing more harm. But this, like the way it's set up, it sounds like leaving space for all the humans impacted to just have a minute and be human with each other. And I don't think we need tons of time, but like that's the kind of small spaces every day or just as often as we need it, they can add up to like the difference, you know?
For sure. I mean, and M&M rounds and those kind of things have their place for sure. But you notice it's so sterile. Like there's often, depending on the discipline, of course, I'm casting a wide, brush when I say this, but there's often very little space that's left for talking about grief and loss. In an
Yes.
M&M rounds, it's more like what our system did wrong, what could we have done better clinically, right? But
Yeah.
what about the people? What about how the people were impacted, right? I
Yeah.
think that's often lost in those conversations.
That's it. This is listen, I'm not like doing a takedown of M&M rounds per se, but I think it's a good example of how I think some, and you co-sign or no, don't co-sign, okay? But like I just have this view of our system, a lot of times they're sort of behind sort of the guise of say professionalism, or even like sometimes we use the evidence-based or science or process, and we use it in a way to dehumanize and to say, let's be objective about this and look at the facts in a way that seems like it's actually just sort of removing, well, for the conversation from being like really relevant to the humans that were impacted from it. But also, I don't know, there's something about it that just ends up um, can be actually harmful in the end because it doesn't leave people space to feel human. So instead, if, as human beings, we actually just have emotions about a thing and we don't think in algorithms, then we feel like we are out of place in our healthcare system. You know
Yeah,
what I
for
mean?
sure. Yeah, totally, totally, absolutely. And until we create those spaces, I think we will continue to see more and more injury, compassionate fatigue, and all-out burnout amongst healthcare workers. I mean, we saw what happened to healthcare workers during the COVID-19 pandemic, and I mean, I'm not sure we really learned our lessons.
Oh,
And so yeah, this is such an important piece, and I know we'll be talking about this much more as the years go on.
yeah. I'm curious from your vantage point, like seeing advocacy policy, like work to change policies, as well as like front lines people who are so horribly impacted by structurally unjust systems. um so grief circles being like giving space for grief being one example. Do you have other examples of what you can see really needs to change about our medical culture to rehumanize it? Because as I have this theory that one powerful way to end up helping more humans as patients is if we are rehumanized ourselves,
Yeah, for sure. Yeah, I have a couple of thoughts on that. I think we in an evidence-based world, as you mentioned, we're so focused on numbers and quantitative evaluations, and I think that's really important. Of course, don't get me wrong. I
Yeah.
think we need to go back to focusing on the narrative, the power of story, the
Yeah.
power of a person-centered experience. And I think it's the power of story that really brought home the Peach program, right? And I think sometimes in palliative care, I think as a discipline, we probably do a good job of that in that the power of story and the power of narrative to really center a human experience. And it's amazing to me how Canadians are so compassionate towards our Peach clients whenever we go public with a story or we share some news, or it's incredible to see, and that just really it can really move people. And names and faces and their stories sometimes can totally trump, numbers and statistics, right? And so we have to remember that. I think the second could potentially, be should definitely be that we should involve the people we care for in our health systems more. It
Yeah.
blows my mind that we've gotten all these years and we've like design healthcare, and patients or what have not been part of this experience. And so just recently you've seen more of a push towards patient-centered co-design, right? Where you're seeing patients being recruited by healthcare institutions and different kind of bodies to be part of the actual delivery of framework, or the develop the blueprint of the delivery of healthcare. And I think that's really, really good. I think sometimes though we have to think of the inequities in that the kind of people who are getting recruited are
Mm.
typically not the people we care for within the Peach program, who are unhoused or maybe experiencing poverty because they've got other priorities, right?
Mm.
And so we have to be conscious of some of those inequities that may accumulate over time. But I think that's really important. And then I think we need to integrate more with the social service sector, because I think sometimes we in medicine and healthcare think we know what's best. But I got to tell you, as someone who's worked in shelters and in the housing sector, I've learned so much from my housing colleagues, who have been caring for people in complex situations for a really long time. When you do that, you start to realize the power of two-way learning.
Mm.
One of those examples is that we realized very quickly that there's a lot of privilege being in medicine and in healthcare. And one of the ways we've been able to address that is by having a peer worker on our team. So we have a person on our team who has experiences of being on the street, and we just got some grant money to be able to put that in place. So have a peer worker on our team, so that person can actually work with our clients and build a different kind of trusting relationship with them. It's that kind of thing that when you really dig deep and you really kind of get into the spaces and the lives of people and you understand the kind of things that can be really helpful for them. That's an example of that.
I just wrote down power of two-way learning because I am obsessed. Like that's I again like they're not going to make a bunch more healthcare workers in time. I think if even if someone was not interested in social justice and well, but like just numbers wise, I think inviting patients in to collaborate and let us know how to get more efficient in care because it's actually what matters to them. Doesn't that just make sense anyway? You know, like it's so interesting. I just think that's so powerful. And I'll love to hear how it is having someone literally be paid to be a part of the team and how that shifts um how care is offered, how it's communicated, like all of those pieces, you know?
Yeah, absolutely. I think it's just really important to not think at any time that we know what's best for the people we care for, and to
Mm.
continuously create iterations of learning so we are, humble in our approaches and are willing to learn. I think that's really what trauma-informed care is really about. And so I hope that we're talking more about trauma-informed care in the coming years in healthcare as well.
Yes, me too. I think I have said it explicitly, but a lot of the concepts I talk about I learned from trauma-informed care. I think the thing that I want to make pe sure people know is that trauma-informed care is technically also like easier and more satisfying for us as clinicians. It's not harder and more waiting in funny territory. It's actually just like, hey, we get to share the power in this room. Hey, they get to actually tell us a couple things. It's less pressure on us to know everything,
Mhm.
you know?
So true.
Okay, I have like it's a slight shift of a question, but I know a lot of people who listen to this and like say people I work with are not doing work on the scale you're doing where you're like literally talking to the media. But I also know that even so, so many people are fearful of doing things that feel more authentic to them, feel more in line with their values, doing some version of an atypical model themselves because they're afraid of the judgment of others, even just the judgment of colleagues, but certainly it's like a common catastrophizing, like, oh, if I do what the patient says, but it's not the guidelines, and somehow that I'm going to be shamed in the public. It's one of these things that it's a common thought pattern. And I mean, you have put yourself out there not, I'm sure, because you were excited to get the judgment of others, but I would imagine you've had to build up a real sense or an approach to how you do this work by being so public. Like, what is your view on, and how do you manage the notion of others' opinions of you?
Yeah, I mean, I think it's a really challenging kind of thing, and I'm sure you're probably aware that myself and many of my colleagues faced immense strife during COVID-19
Yeah.
and during the pandemic. Many of us received threats, vile insults, discrimination. I mean, I had a person, send to my office, the office that I'm associated with, a threat,
Oh.
and it goes on and on and on, right? And these are physical threats, this is emotional violence, right? And so
Mhm.
I wasn't the only one, but yeah, I mean, I was one of the people who definitely got that. And any of us who were in the public talking about evidence and science and promoting vaccines and whatnot
Yeah.
during COVID kind of got that. And so, at first it was like quite shocking, and then later on, I just have to say it just kind of became part of what the work is. We live in a more hyper polarized world than ever before. I think anyone that does any advocacy work has to know that there is going to be some resistance to concepts and ideas, and depending on the day and the topic,
Mhm.
you'll find that resistance. I think safety is paramount and most important. I encourage people to advocate and work from a safe space, and I recognize that not all people are able or have the privilege to be able to do the kind of advocacy that I do for a variety of reasons. And that's why I'm so grateful and honored to be able to do it, and I take it so seriously.
Yeah.
Yeah, this the second kind of way to answer that question is, I think in a world of like, virality and likes and reshares, you can get really caught up on, one can really get caught up on sort of those kind of metrics
Yeah.
and trying to, be popular or whatever. I tend to really not focus on those kinds of metrics, albeit they might be measures of success over time. I don't want to say that they're like useless, but
Mhm.
they aren't the core of what drives things. Ultimately, when there's an issue, whether it's the city of Toronto, treating unhoused people in an encampment inappropriately,
Mhm.
or if it's misinformation around COVID-19, or if it's about a provincial government not providing support for workers appropriately. I always really center the voices of the people I care for and their perspectives. And that's my North Star. That's what guides me. Because it's easy to get lost along the way.
Mhm.
There are a lot of pressures, there's a lot of distractions.
Yeah.
And that is always what guides me. And I think those are two key concepts when we're talking about something like this.
Yeah, that leads so well because I was curious how you know which work is yours and what you say no to. I know was talking about boundaries before with like patient care, but like I'm imagining there could be almost like scope creep that happens where it's like, hey, can you talk on this? Like, what do you use as how do you know what work you want to spend your time on? Because there is only so many hours in the day. How do like what do you use as your sense, like you said, your North Star to understand what work you do best?
Yeah, I think, truly, whenever I speak on an issue, it emanates from, my clinical frontline work.
Mm.
And one of the advantages of working in palliative care is actually I work in every setting of healthcare, from
Yeah.
hospital to clinic to home care to hospice to long-term care to the shelter and virtual and everything in between. And so when you work in every setting, you get a really interesting vantage point on the human condition.
Mm.
And at a time when people are very vulnerable, when they're very sick, right? And
Yeah.
sometimes when they're at end of life. And so I'm not trying to say that, oh, that means all of it is my work. That's not what I'm trying to say. But what I am trying to say is like that's how I know that's really the entry point to a lot of these experiences. I'll go visit someone who's in a shelter who's dying, and he's on social assistance, and he's in a shelter and he can't afford food anymore. And I think this is so stupid. Like, how is this happening? Right.
Mm.
And, write an op-ed around food insecurity and we need to raise the rates or something. Um, or, during COVID-19, I saw many people who were sick and dying in hospital, and I was doing palliative care consults on them because they didn't have adequate paid sick days. So they went to work, got COVID, and ended up in the ICU. And there I am, talking to their family about withdrawing care and end of life, right? And so I got really passionate about paid sick days, right? So it really does emanate from that work. I think we also, as a medical culture, have to be very careful about the word expert. You know,
Mm,
um, I mean, I recognize that I have mad respect for my colleagues in infectious disease who are clearly experts on infectious disease, but in a pandemic that affects all of society, like who's an expert? What is an expert, right?
yeah.
Certainly, my infectious disease colleagues played a huge role, and they will continue to play a huge role, moving forward. But when it came to the experiences of unhoused people during the pandemic, I may have been a palliative care doctor, but as an advocate and someone who was able to speak to the voices of those who are, impacted on the streets and in shelters, I had to speak out. It didn't feel right. And when you couple the expertise of an infectious disease doctor with someone like me, like what happened many times in, on a panel on the TV or something or the radio, it produced a very powerful, output, because you've got that real medical infectious disease expertise, but then you also were talking to a physician who literally is out there doing that work and understands the experiences of folks who are on the streets and in shelters. And so I think we need to be kinder to each other about what
Mm,
expertise means. I think we need to think not like 2D, like 3D. Like we need to really see all the dimensions of what expertise can look like, and
mm.
recognize that it may not be that typical breakdown of the disciplines of medicine. You know what I
Totally.
mean?
Oh, a
Yeah.
hundred. I mean, like they are like arbitrary and they don't fully make sense. You know, that and I'm not saying we're like abolishing all specialties or anything, but like there's the lines are very strange when you apply them to humanity where I mean, like often it's not just one organ anyway, you know?
Yeah.
And I really like expertise. Like there's the knowledge bit, but like also another way of thinking of expertise is who has the most experience, you know, like
Mhm.
that's got to be at least equal weight. And you're speaking to that. Like, so that makes sense. Like you don't have to like sit and really brainstorm what you're going to write about. It's like coming from your heart anyway, right?
Oh, for sure. Yeah. All,
Yeah.
whether it's an op-ed or a media interview or a tweet or a post, like it's all coming from some experience on the front lines that myself or my colleagues have seen. And something that is impacting and related to, health justice ultimately. And that's really where all of this comes from. Sometimes the way it's expressed is more art, and sometimes
Mm,
the timing is strategic, right? And the
mm,
direction of who we're pointing the issue at is strategic, but it
mm.
all is centered around my North Star, which is the people we care for and their voices.
So lovely. Um, I was thinking about was there oh yeah, this was one of my questions. So how do you think we need to shift our definition of health in order to address outcomes that matter? I mean, it's sort of funny talking, especially to a palliative care clinician, because I mean, sometimes when I don't know, say like what the health industry is focused on, they don't want to talk about palliative care because you don't want to talk about the
Mhm.
fact that people are all mortal. Um, But I was just curious of what your answer was to that question of like shifting our definition as a society, but certainly in medicine as well, so that we're really, yeah, looking at outcomes that matter the most to everybody.
Yeah, I think that's a really good question. One of the first things we need to do is look at the current outcomes we track and really think if they're really equitable to begin with. In the palliative care world, one of the most popular metrics in community-based palliative care is percent of patients who died at home. And I just
Oh.
ask you to think about what that means for the PEACH program. I've always had a huge problem with that metric because it's not fair to us or our clients, right? Even if we are able to keep someone, in a shelter, who has cancer for 2 years, and on the day they die, they end up in the ER. That tracks as a negative for us, right?
Wow.
But like we kept them in the shelter with their, street family for 99% of their trajectory. That has to count for something. So that's an example of
Yeah.
how our metrics are not always kept in, not keeping in mind the populations, not all populations, for example. I think the
Mm,
second is we really need to move towards patient-reported outcomes, patient-reported experience metrics, and I think I'm seeing more and more of this in the research, and I think this is starting to become. I'm not the first person to say this is like a very common thing now, and I think I'm glad to see it's more commonly being described, that we're not just looking at outcomes of healthcare utilization or ER visits or length of stays. We're actually talking to people we care for and we're getting their experiences. So I really do actually very much so kind of, I do promote that. And I think that's a huge part of it as well. But I also kind of think that if we don't actually include patients in the design of the metrics of what matters,
Yeah.
then we will have a tendency to collect things that don't actually matter to patients,
Hmm.
and sometimes we will run amok and like go in the wrong direction. And so I think that has to be a part of it. I know I mentioned that already, but it is such an important piece for this kind of issue as well, right?
Yeah. How has that been with Peach and your patient populations in getting their input on like ongoing iteration and design?
Yeah, for sure. I mean, I think when we implemented the PEACH program, it was designed with people who experience homelessness advising us
Hmm.
in an iterative way over the first 3 years, and that was really important to have the steering committee guiding us and really pushing forward. As the years have gone on, we've collected data in different ways. We focused on our grief circles and the data around that. We focused on a program we run called the Good Wishes program, where we provide gifts. It's like the Make a Wish Foundation, but for unhoused people who are dying. And so
Hmm.
we provide gifts for people who are dying, and it can be a gift certificate to a dinner or Blue Jays tickets, or it can be anything, right? It can also be something very practical, like a shower curtain or something, like just necessities of daily life, like a bed or something, right?
Yeah.
Um, and so we've tracked those kind of metrics. What we've tried to do is move away from, just collecting medical healthcare utilization data, for example, and start to move towards psychosocial data that also shows the heart of our care, not just the nuts and bolts, but our heart and soul as well, which I think is such an important element of things as well. As we start the peer worker program, we're really going to think about how to evaluate that and how to bring in like a peer's perspective on the team.
Yeah.
And some of this has been done before, some of it's a little bit novel in the space, and so we have to create it as we go along. So yeah, it's kind of balancing the traditional metrics, but also moving forward to collect some of those other metrics too.
Yeah. Oh, I love that Good Wishes program. That sounds incredible. And the steering committee was completely made up of unhoused folks. Like that's like who your
Yeah,
steering
yeah,
committee
yeah, and
was.
was based at the Inner City Health Associates at the time of launch, and that's been hugely instrumental in the way we've operated the program since the beginning.
That's, I just, I know this is tough work you're doing, but I'm just like smiling over here. I just think this is the kind of model that you doesn't have to just apply in this one setting. And I know maybe there's things unique about how things were set up that, but I don't, it can start as small as even yours started, which lots of failure. And you said like just you and a Honda Civic 1 day a week, right? Like it can start
Hmm.
small, even smaller than that. But um, some of these principles, like it's a different way to invite change into the system, isn't it? And I think we need new
Yeah,
ways.
yeah, I agree with that.
Yeah. Okay, I have one last question that's like again kind of a tangent, but I really okay, so the name of the podcast is like the other human in the room, right? And so you being a human who has all this incredible work you're doing in the healthcare space, but like in terms of how you stay human, most people have whatever it is, like their favorite things to do, shows to watch, practices, like what is it that helps you stay human outside of medicine that then allows you to stay engaged inside of medicine?
Yeah, I mean, I think one of the things that when you do this work, whether it's like my hospital or community work or hospice work, where I'm caring for a significant number of people who experience structural vulnerabilities like poverty and homelessness, is that you tend to abut against system failures
Mm,
consistently throughout the day, every day for the people you care for. And that can be really difficult, and that can lead to a lot of compassion fatigue. And so for me, I could never imagine doing this work in a vacuum.
Mm.
This work being like clinical stuff, the education, the research, without the advocacy, right? And don't get me wrong, like I go to the gym, I like running, like
Yeah, good.
I like going out and having going to restaurants and stuff like that. And my wife is a huge supporter. So are my parents, and I'm lucky to have them. But I think for me, really, if we really drill down to what actually keeps me human, it's actually advocating around some of the issues that I see on the front line. So if I had
Mm.
to go out there and care for unhoused people who are dying every day and then like just bottle that, I think that would not bode well for me, personally, in a multitude of ways. So, I get home and I get riled up, and I write letters to politicians, and I tweet, and I join advocacy groups, and I speak at protests, and utilize social media channels to put information out there, and bring people along for the ride, as well. And so I think if the activist component was not part of the work, I don't think I'd be centered in the ability to do this work moving forward as a human. And
Yeah.
so it just one thing leads to another, which leads back to the original
Mm.
start. Yeah.
I wonder, and there's sort of two elements in there that I bet are useful. Like there's an element of almost creativity that in terms of clearly you enjoy speaking, you enjoy writing, and you get to do it in about a topic that you have so much passion about. But like we know that creativity is like it doesn't have it can be something that doesn't have anything to do with your day job. You could be a painter, but like also like creativity in terms of how you express yourself to the world, like that literally for your body and your brain could be generative, right? And then that you do it in community, and so you're connecting with other people. Those are two elements that I just know of because this is what I'm really interested in, is like what are the building blocks it takes to like really maintain ourselves out of that survival mode and in like an abundant place where we are able to really restore ourselves physiologically as humans, you know? And
For sure.
so I just think that's kind of genius that you did that. You found your
Well, thank
ways
you.
to do that, you know?
No, I appreciate it. I think it's more out of necessity that it kind of happened, because I just couldn't see it happen any other way. But yeah, I mean,
Mm.
it's working for now at least. Who knows how this will work over time? But it's
Yeah.
certainly all kind of like it's a package. You can't have one without the other, you know?
Yeah, there's something about, I know like pretty early on in practice in primary care and just like seeing all of the cracks of the system and like I was like, okay, I definitely need to at least do one thing where I'm working on the system level because I can't, otherwise it's hard to like look at patients in the eye and be like, this is how the system is. And for me, and it sounds like for you, like there's a call to try and do better for the patients, knowing it's not your responsibility, but it
Hmm.
it helps you look in their eyes a little more, doesn't it? I don't know, just for
Yeah.
me, you know?
Oh, for sure. Oh, for sure. For sure. Really well said. I think that's so true. So true.
Yeah, otherwise then you end up just feeling like you are a spokesperson for the broken system, and it's a no thank
Hmm.
you for me. So
Hmm.
it's like
Yeah, totally.
not going to defend it at all. It's all falling apart. Okay, well, I think we're at the end of our hour together. So, yeah, I guess first would be, is there anywhere that you'd like to direct people, both to learn more about you and follow your work, as well as about this issue you're really passionate about? Like, how could people learn more about it?
Yeah, for sure. I mean, if you're interested in, joining the movement, I'm on Twitter and Instagram, at Naheed D. That's Naheedd. And through there, I think, you'll really get exposed to a lot of the different organizations I work with, and then some of the movements that we're working on. If you're interested in learning more, I'm really actively involved with a few organizations, including Health Providers Against Poverty, the Decent Work and Health Network, Canadian Doctors for Medicare, Doctors for Defunding Police, and Doctors for Justice in Long-Term Care. So feel free to kind of check out some of those organizations and groups. And I think there's a lot to be learned on those channels.
That's amazing. That's quite a list. You are a little busy, hey?
A little bit, but
But doing good work.
yeah,
So hopefully
yeah,
it's
thank you.
generative, right?
Yeah, yeah, for sure, for sure.
Okay. And then, yeah, I mean, speaking human to human, what is it that if someone's really either they're in the advocacy role in their own community, but they're really struggling, or someone who's listening and they're like, I don't even think I have time for advocacy, but I already feel burnt out as it is. Like, what kind of advice or encouragement would you want to give all the folks who are listening who are trying to take care of the other humans?
I mean, you don't like, you don't have to do something new and different to be an advocate, right? Like that to that point of that person you're talking about who says they're already, feel like they're stretched. I mean, you can just really do the work on the front lines at that micro level. You can care for the person who's in front of you. Some people work at the meso level, like the Peach program is like a neighborhood or community level intervention and social accountability. And some of us work at that macro level, at the systems level, like you said, to work at improving access to care holistically, public health issues, or writing a petition nationwide to the prime minister to end homelessness or something. And this social accountability framework was written in 2016 by colleagues in Canadian family physician, Dr. Sandy Buckman, one of my mentors, and his colleagues also wrote a bunch of articles on this. And it's still like a really powerful series in my opinion.
Hmm.
And you kind of picture that avocado where the micro level of advocacy or social accountability is that seed, and then the meso is the flesh, and then the macro is on the outside. And some of us work at the micro level our whole lives. Some of us work at all three levels at the same time. Some of us work as we go through our career and work more at the at the meso than the macro over time. We need it all. Like you can be socially accountable um, at any of those levels, and we need all of those levels to be operating. So I would say that that's something to think about.
Oh, I love that. Yeah. You don't have to do anything new or different. I just think I mean, it's such a relief, right? Like you say, we need all of the pieces. That's how happens, is it happens individually and collectively all at the same time, you know?
For sure.
Well, thank you so much for your time, Naheed. This has been a wonderful conversation.
Thank you so much. I really appreciate it, and wishing all of your listeners the very best. And thanks so much for everything you do.
Hey there, healthcare humans. I want to invite you to sign up for my course, How to Stop Worrying About Your Patients. It's a free 5-day email course delivered right to your inbox where I teach you why worrying is optional, that it's not actually helpful for your patients, and that it's possible to reclaim your brain from worry and start enjoying your life in and outside of medicine. Go to joanchanmd.com/course to sign up now. I'll see you in your inbox.